Our next speaker is actually a colleague of Dr. Johan's over at the UK Markey Medical Center, where they work with Lowell Anthony, MD, when they're working with the Neuroendocrine Cancer Clinic. She's here today to bring us information regarding imaging scans for NET patients. So please welcome Dr. Riham El-Khouli.
Thank you very much, Bob, for the introduction, and good afternoon, ladies and gentlemen. Thank you for attending the conference, and I'll be talking about advanced imaging. So we're kind of switching gears here about more imaging, which will include some therapies. I have nothing to disclose. So we all know that neuroendocrine tumor is a rare tumor that originates from neuroendocrine cells, which is actually spread out in all different organs. And they usually are classified by the site of origin because they share, they have specific features related to where they arise from. Yet they actually share a common feature, including the growth pattern based on the grades and the exhibition of certain markers. Talking about neuroendocrine tumor, we have always to talk about somatostatin because it has been the focus of a lot of treatment and imaging trials and standard of care. Somatostatin is growth hormone inhibiting, so it's kind of a hormone that actually binds to a surface receptor and affects the neurotransmission and cell proliferation. It binds to what we call the somatostatin receptors. There are 5 types of them. We usually are interested in somatostatin receptor type 2 because it's expressed more heavily on neuroendocrine tumors rather than normal cells. There are multiple, like of course neuroendocrine tumors, well-differentiated low grades, always express somatostatin receptors, but there are other tumors that does the same. So I will start with what were the challenges facing imagers when we were talking about neuroendocrine tumor. Why historically we were not doing a good job finding the neuroendocrine tumors early enough. And the reason of that is the nature of the tumor. It's a very hypervascular tumor that actually takes the contrast that we inject very early and washes it out very early because it has a lot of vascularity. So I'm showing you an example here. This image is a delayed contrast enhanced image. This is the liver. This is the IVC, which is a large vessel in the abdomen. It should look like that. There's some vascularity, but you all can agree with me there's no lesions I can see on that image. I will just show you the same study, but the arterial phase and the venous phase. You can see here these two dots that are white. These are metastatic lesions in the liver that are arterially enhancing. The problem is that in the venous phase, it blends. You cannot see it or recognize it in the venous phase or the delayed phase. So the old scanners were very, very slow. So we were able to get imaging at that phase. So we were missing all the arterial enhancing lesions. In the early 90s, with the development of the helical CT, which is a fast CT scanner, it was a big step up for us because finally we were able to image at the arterial phase and see the arterially enhancing lesions, including neuroendocrine tumor, and that affected our ability of detecting these lesions early on. Just a couple of years later came the Octoscan, and a lot of you most probably know about the Octoscan, which is a somatostatin analog attached to radio tracer or radioisotope, so we can see by our imaging. As we said before, there are multiple somatostatin receptors. We can all imagine that this is a neuroendocrine tumor cell, and these are all receptors binding on the surface of the cell. If I inject my radio tracer, what will happen? It will come and bind to that receptor, but this somatostatin analog is actually carrying radioactive material that I can see with my imaging. These since the invention and the development of that radiopharmaceutical, it was revolutionary in our life because finally we have a targeted imaging tracer that we can see somatostatin receptor expressing tumors. I'm showing you here an example of an Octoscan, a whole body image. This is anterior, looking at the patient from the front, and this is posterior, looking at the patient from the back. And these are the kidneys, which is normally like that, but all the other like dark black dots are actually lesions. You can see a pancreatic mass, and we can see multiple liver metastases, supraclavicular lymph node, some bone metastatic lesions. So since the development of Octoscan, it became an essential part of the standard workup of patients with neuroendocrine tumor. It has a very high sensitivity, 80 to 90%, and actually it resulted in a steady increase in the incidence. And the incidence of the tumor means the number of new patients with the disease every year. And this is just showing you based on our national data, the SEER data from 1973 all the way to 2012. And you can notice here that at 1994, this was the start of the steadily increased incidence of neuroendocrine tumor. And it's really believed to be because of the advances in imaging rather than the real increase in the number of cases. It's just we can find them much earlier now. Always when you find the tumor early, you have much better and much more treatment options than when you find it late in the disease. I said that Octoscan was revolutionary. It is, but dotatate, gallium-68 dotatate is a new era with neuroendocrine tumor. Why? Because it's a PET tracer, and I'm showing you here what the same patient, a dotatate PET CT, an Octoscan, just 2 months apart. And we all know with differentiated neuroendocrine tumor, it's indolent, slow growing, so there's not going to be much change in the biology of the disease or the spread of the disease in 2 months. But you can easily see here the image quality is much better with dotatate. The detectability is much better. All these lesions with arrows, I cannot really see in the Octoscan. They are clearly recognized on the dotatate. So it's better image quality, better detectability, better accuracy. Not only that, it's actually, why is that? It's because the technology, PET-CT scanner is higher technology, much better scanner than SPECT-CT. Plus the characteristic of the radioactive material is different. That makes any PET tracer better than any SPECT tracer. Not only that, actually, it's much less radiation when you give dotatate versus you give Octoscan. So when you give Octoscan, you're giving 5 times more radiation to the patient than when you give a dotatate. And here we are comparing the standard dosage that we give to the patients in each radioisotope. All of us care about the logistics, right? I'm going to a physician clinic. All I care about, how long am I going to be there? When I'm going to be out of that place, right? All of us feel like that. I go to my physician, I'm always, this is what I'm thinking about. Is this going to take me an hour, 2 hours? I really want to move fast, right? So let me walk you through a regular day for a patient coming for Octoscan. We inject our radiopharmaceutical, have the patient with us in the hospital for 4 hours, to come back for a 60-minute imaging. We ask the patient to go home and come back the next day, 24 hours later, for another 60 minutes imaging at least. And then he might be done, he might not, because sometimes we need the patient to come back for 48-hour imaging. And so we're talking about 2 to 3 days scan, patient coming forth and back to the hospital multiple times. When we talk about dotatate, on the other hand, patient gets the radiopharmaceutical, stay with us for 1 hour, a 30 minutes imaging, and he's done. So it's an hour and a half, 2 hours at most, between the registration and bringing the patient in, 2 hours, not more than that. So even logistically, it's much better, much easier for the patient. So simply, it's one of the situation in life, the rare situation, I think, where it's a really win-win situation. I can't see any advantage of Octoscan versus dotatate. So since we started in University of Kentucky offering our patients dotatate, we basically stopped offering Octoscan. We rarely get some requests for Octoscan, but we always call the physician and tell them that we have a better tracer, same price, and better in everything. So really, we shifted to dotatate. I cannot see a good reason why would I do an Octoscan while I have a dotatate capability. Right? So another advantage of not only dotatate, but when we do what we call in our word dual tracer, which means 2 different types of radio tracer or 2 different types of radioactive materials. You will notice here I'm saying gallium dotatate and I'm saying FDG. FDG is actually a radioactive glucose that we inject to the patient. And this is the basic radio tracer we use in PET a lot. Okay, let me go back a little bit and talk about the grading system for the neuroendocrine tumor. We have 3 grades. Grade 1 is a well-differentiated, low grade, right? And it's indolent, slow-growing tumor, almost benign behaving tumor, right? And then we have grade 2, which again, well-differentiated, a little bit more aggressive, but still within the slow-growing indolent era. And then we have a grade 3 poly-differentiated tumors, which actually are very aggressive tumors. In PET-CT, we know that glucose actually is an indicator of cellularity and aggressiveness of tumors. So when these are the same cuts, right, of the same patients, but using 2 different tracers, a dotatate and FDG, and they are done usually in 2 different days. All right. When you look here, you will find there's a lot of FDG uptake in that lesions. You see all these yellow dots are actually metastatic liver lesions. They are very, very FDG avid. What in dotatate, we barely can see them. This tells me that this is a high grade, a grade 3 tumor, right? An aggressive tumor that is utilize or uses a lot of glucose, but actually it does not express a lot of the receptors. On the other hand, when we look at this patient here, the same scenario, it's the dots here flipped, right? There's a dotatate avid or somatostatin avid tumor in the liver, while I can barely see anything above what the regular liver look like in FDG, which tells me that this is a well-differentiated, expressing the receptors, low-grade neuroendocrine tumor. And the grade 2 is usually takes variable degree of both tracers. So doing these, oh, I'm not sure what happened. Sorry, just 1 second. And if I can go here and go directly, I should be good. Okay, yeah. So now let's go. I'm sorry for that. Let's give you a couple of examples. These are 2 scans for the same patient done 1 month apart, a dotatate PET-CT and an FDG PET-CT. As we see here, this is anterior, this is lateral. And you see a lot of lesions, right? A lot of lung lesions, bone lesions, liver metastasis, small bowel, right? When you look at the FDG, it's basically clean. This is the liver, how it should look like. This is the spleen, how it should look like. There's no lesions I see. So these lesions don't have matching lesions in FDG, which tells me that this is a grade 1 neuroendocrine tumor. Another example, pulmonary neuroendocrine tumor, a hilar mass that is both FDG and dotatate avid, right? So again, metastatic bone lesions, as we see here. So this tells me what? It's a grade 2. Usually grade 2 is the grade where I see both FDG and dotatate activity. And the flip effect. This is FDG, this is dotatate, 4 months apart. Again, a lot of liver metastatic lesions that are FDG avid or glucose avid, while I can't see anything in dotatate. So this is actually poorly differentiated grade 3 neuroendocrine carcinoma. Another cute example of how using different tracers, giving you different information and can understand more biology of the tumor is that we have here a dotatate and an FDG, multiple liver lesions that are dotatate avid, not FDG avid, which tells us that it's a grade 1 well-differentiated neuroendocrine tumor. But there are actually lymph nodes here in this region beside the liver that I cannot see with dotatate, and these were biopsied and came back active sarcoidosis. So this patient had 2 separate disease processes going on. And the 2 tracers can highlight that these 2 lesions are separate biology. They're not the same biology. This is what we can do with imaging. Okay, I would like to talk a little bit about theranostics because I feel it's very important, and neuroendocrine tumor is one of the big tumors that we are using theranostics in. And actually, it's not a new technique. We've been doing that for decades in nuclear medicine, but the name, the theranostics, is a new fancy name for that technique. What is the concept of theranostics? The concept is that we combine a targeted diagnostic and therapeutic agent. What does that mean? It means that I have a biological target like somatostatin, like analog that binds to somatostatin receptors, so it can target specific cells. and then I attach it to a diagnostic radioactive material to image and see where is the disease exactly. Then I attach the same targeted part to a therapeutic radioactive material to treat with. This is why it's called, it's combining these two. Okay, where did the name come from? So the name came from combining the word therapy to diagnostics. So these blue parts will go away and they attach the beginning of therapy to the ending of diagnostics, and it becomes theranostics. So this is where the name came from. Just to give you a graphical example to understand the concept, let's imagine these are neuroendocrine tumor cells, and they express the somatostatin receptors. As we know, this is well-differentiated neuroendocrine tumors, so it expresses the receptor, right? I inject gallium-68 dotatate for PET-CT imaging. It flies in, the somatostatin analog binds to the receptor, and this is the PET radioisotope that emits radiation that I can see with my camera. And I image the patient, I see where is that. Then the same cells, the same target, I inject my treatment, the lutetium-177 dotatate, which goes to the same target, but in this time it's carrying therapeutic radioactive material that can actually kill the cells. Okay, I'm giving you so it's revolutionary again for our, and Dr. Chauhan already touched on that, the NITR one, which actually led to the FDA approval of the Lutathera or lutetium-177 dotatate, or what we generally call this group of treatment is peptide receptor radionuclide therapy, PRRT, and it did show advantage in risk reduction of disease progression and death. I'm not going to talk a lot because also I just wanted to introduce to my next speaker talking about PRRT. What we do, we give 4 doses of specific dosage, roughly 2 months apart, right? And we do follow up with look at blood levels and make sure that everything is good before giving the next drug, the next dose. In the day of, we start with amino acid, give at least 30 minutes, then we do a 30 minutes of our radioactive therapy, and then continue with another 3 hours of amino acid. The reason we give amino acids is to protect the kidney, because the kidney is the organ responsible for eliminating the lutetium-177. I'm touching on that because I will show you the imaging, because in University of Kentucky, we ask our patients to come back 5 days later for imaging. So this is the patient here that came to us with metastatic pulmonary neuroendocrine tumor. As we see here, this is the primary, multiple lymph nodes and bone metastasis, liver metastasis, and lymph nodes in the abdomen as well. And these are cross sections showing you here. This is bone mets here. This is the bone mets. This is the bladder, liver metastasis, the pulmonary mass. Okay, the patient came back to us a year later looking like that, like obvious disease progression. So, and all the disease is actually expressing somatostatin receptors, as we can say from that dotatate scan. So we decided to go ahead with PRRT. And like I said before, we ask our patients after each dose, 5 days later, to come for imaging. And this is the imaging after the first dose, imaging after the second dose, third dose, and fourth dose. And you can simply see that the level of activity is decreasing. If you pick one lesion and go after it, you will feel that you see the activity is decreasing, right? Okay. Another thing I want to talk about today is what's really happening right now in imaging world for neuroendocrine tumor. Copper-64 dotatate, which they call DetectNet, right? This is a new tracer that was just approved by the FDA in September. Why is it a big deal, right? We already have the gallium-68 dotatate. I'll tell you why is it a big deal. Because one of the limitations of gallium-68 dotatate was the generator. Because the generator, you have to have a generator in your area to be able to offer your patients gallium-68 dotatate, to be able to produce the tracer, right? And although now we have a lot of generators in the US, still it's not covering everywhere. There's a lot of patients that don't have available tracer in their nearby PET centers, and they have to travel for 2, 3, 4 hours to get the scan, right? Which limits the spread of that. what's nice about the copper-64 dotatate is actually it's a cyclotron produced, which we have, but cyclotrons are everywhere. Not only that, the half-life, which is actually the time it takes for any radioisotope to go to half the activity, is 13 hours for the copper. It was only 1 hour for gallium-68 dotatate. So now not only we have cyclotrons everywhere, but also they can produce it and ship it 2, 3, 4, 5 hours away, because actually the half-life is too long and it can survive them shipping and calibrating. So I think the nice thing about it, there are other technical aspects of it, but I'm not going to go into that. But actually the real advantage is that I think the approval of copper-64 dotatate is going to result in widespread use of dotatate PET-CT tracers. The initial trials showed good reader agreement and accuracy also. So to wrap up, during the last 3 decades at least, there were significant advances in imaging of neuroendocrine tumors. And I really truly believe that these advances have greatly impacted the incidence and the management of neuroendocrine tumors. And then the coupling of the diagnostic and therapies of these tumors, these targeted therapies, is a significant breakthrough, right? Sternognostics is a new term, not a new concept, but it combines the diagnostics with therapeutic techniques like we discussed. Gallium dotatate PET-CT, and I think copper-64 dotatate PET-CT is the new standard molecular imaging modality of choice for assessment of neuroendocrine tumors. It's also the standard imaging modality to determine PRRT eligibility, because you will see, does this patient have enough lesion that expresses that receptor, that target for me to treat through, right? This is what it means. And of course, PRRT proved 79% reduction in risk of progression and death when compared to the cold octreotide. Thank you so much for your attention.